Ladies and gentlemen, thank you very much for the invitation to talk to you today about COVID in the heart. My disclosure, as you'll see, is that I'm a cardiologist, and therefore I've actually spent the last few months with three hats on, not only continuing to deliver cardiovascular MRI, but also looking after COVID-19 patients on the ward and conducting research into COVID in our asymptomatic healthcare worker population. When we think of COVID-19 in the heart, as cardiologists and imagers, we really have four main questions that we need to address. Firstly, are patients with cardiovascular disease at higher risk? Secondly, does COVID-19 itself directly affect the heart? Thirdly, when should I consider CMR in my COVID-19 patients? And finally, how should I be best running my CMR service during the COVID-19 pandemic? And this last point I think will be covered largely by James in the next talk. So looking across hospitalised COVID patients, and here I present UK data that was collected prospectively on over 20,000 hospitalised patients, of whom 26% subsequently died. We can see that almost a third have chronic cardiac disease, and often this overlaps with other comorbidities. But importantly, we also see that alongside age, chronic cardiac disease is a relatively strong predictor of mortality, suggesting both that this patient group is overrepresented in the hospitalised COVID population and therefore likely to be at higher risk. This pattern is also reflected with an increased mortality in those with cardiac disease in the Wuhan data, and this group also showed that patients who have a raised troponin as a marker of myocardial damage had significantly worse survival than those with a normal troponin, and the area under curve for mortality was 0.92. But we also must recognise that this raised troponin does not necessarily just reflect myocarditis, but also there's a variety of myocardial and cardiopulmonary syndromes that may be causing this, including the fact that we know that there's increased thrombotic events in these patients, including acute myocardial infarction, but also many patients who have severe sepsis or are hospitalised on ITU have raised troponin, and so it's difficult to actually determine what the cardiac effects themselves are. So although it's clear that patients with cardiovascular disease are at increased risk of death from COVID, when it comes to addressing the question about whether COVID itself directly impacts the heart, the data is more difficult to interpret. This is an international registry of echo data from over 1,200 patients scanned across 69 countries in 6 continents. And they found that the scans in patients with COVID-19 who underwent echo, over half of them had abnormal findings, with severe abnormalities in 1 in 7. These findings included new myocardial infarction, myocarditis, and Takotsubo, but the findings generally were more non-specific, although the scan did change management in a third of patients. But what this data doesn't tell us is how many of these patients had abnormalities beforehand, how many of these abnormalities are new, how many patients were being treated for cardiovascular problems and were incidentally found to have COVID. And of course, this will be a self-selected sample where the clinical suspicion of cardiovascular problems was high. So this doesn't really answer the question directly. We know that cardiovascular MRI may offer us better insights into understanding myocardial pathology because of the tissue characterization which it delivers, which can tell us about focal and diffuse fibrosis and also myocardial edema. This was one of our patients who I looked after initially on ITU and then subsequently on the ward. He was a 27-year-old Afro-Caribbean who was admitted 20 days following discharge from an initially uncomplicated admission with COVID-19 pneumonia. During that initial admission, his troponin was negative, but on readmission, his troponin was significantly elevated, and his echo shows clear, severe left ventricular systolic dysfunction, and he was rapidly put on ECMO and given high-dose steroids. And actually, his heart recovered very quickly. You'll see within about a week, his systolic function had recovered completely. But his cardiac MR offered additional insights. We could see on tissue characterization that he had high T1 and T2 levels, suggestive of myocardial edema, and there was also focal fibrosis in the lateral wall, suggesting that there was likely to be some scar there as well. But as I've already discussed, the cardiovascular complications from COVID are multiple, and a multimodality imaging approach was often needed in our patients with COVID-19. So this was one patient who was admitted with a thrombotic acute ST elevation myocardial infarction, but actually on multimodality imaging, he was found to have 4 separate cardiovascular complications: thrombotic STEMI, aortic thrombus, pulmonary embolus, and also myocarditis. And we know that in children with multi-system inflammation associated with the COVID, they often develop changes suggestive of myocarditis, but also coronary dilatation and ectasia, particularly in the left main stem, in a pattern that's distinct from Kawasaki disease. So multimodality imaging approach is often needed. But we still have many questions. Firstly, how common are these changes? And I've discussed already how data collection can be challenging because of bias as to who's undergoing imaging. We don't know whether the effects that we're seeing are specific to SARS-CoV-2 infection or whether it's just related to severe sepsis. Are these cardiac changes reversible? Are there long-term clinical consequences? There are many questions still that remain. And several groups have used CMR to try and understand this. This is data from Wuhan in 26 recovered hospitalized patients scanned as a mean of 47 days post-infection. And what they showed is that over half of patients had an abnormal CMR scan, with 54% showing myocardial edema and 31% showing late gadolinium enhancement. Similar data is in preprint format on medRxiv from the Salamanca group. In this time, 139 healthcare workers who had confirmed COVID and who were scanned 10 weeks post-infection. These were a fairly mild COVID infection in the first place, with only 16% hospitalized, but yet they showed that over 40% of patients had evidence of either pericarditis or myocarditis on their CMR scans. But the paper that drew most attention came from Valentina Puntman's group in Frankfurt. They studied 100 recovered COVID-19 patients, of whom a third had been hospitalized, and they compared them against 2 groups: healthy controls and risk factor matched controls. And they showed that there was a lower ejection fraction, higher mass and volumes in the COVID-19 group, and evidence of tissue characterization abnormalities both on late gadolinium enhancement and T1 and T2 mapping. And they showed data from a patient with a troponin level of 17.8 with high T1 and T2 values. The conclusions of the study was that there was cardiac involvement in 78% of patients, with evidence of ongoing myocardial inflammation in 60% of patients. And they presented the raw data both in healthy and risk factor matched controls and non-hospitalized and hospitalized COVID-19 patients, both in terms of the T1, the T2 and the troponin levels. And this paper drew widespread media attention. This probably has the highest altmetric score of any cardiovascular paper ever. It's quoted across 235 news outlets, retweeted over 18,000 times, and was picked up by mainstream media not only in Europe but also in the US. And actually this data was used in conjunction with other data, admittedly, to lead to the decision to stop college football in many US states. So the public health implications of this particular publication were quite significant. But I think we have to be careful in our interpretation of this data. This was an observational, cross-sectional, only moderate-sized study. The comparisons were made across the 3 groups, and so we don't actually know whether the comparisons between the COVID and the risk-matched controls were significant. We also don't know whether, in fact, the CMR effects can be seen in other severe viral infections, because actually no one's looked at this. And finally, and probably most importantly, we don't know whether these CMR changes that are described in over 75%, 78% of patients are clinically significant and have any relevance to the particular patients. And I think this final point is particularly important because this data is being used, rightly or wrongly, to inform public health decision-making in asymptomatic people. When we look at the cutoffs that the authors used here, 2 standard deviations above the mean, you'll see that there's significant overlap between normals or controls and those patients with COVID-19. And when we draw a line for those with significant abnormalities, as defined in the text here by the authors as 4 standard deviations above the mean, you'll see that probably there aren't so many patients who have these significant abnormalities, and possibly the authors may have overstated their findings a little. There are also some concerns raised about the statistical analysis where some of the values seemed implausible. For example, an interquartile range in ejection fraction between 54 and 58, which is just unfeasible for those of us who commonly report MR scans. And the authors and the editors of JAMA responded with some changes to the statistical analysis and the data presented, but not actually the conclusions. So here, as I said, you'll note that the statistics changed, and similarly some of the values changed. So for example, this was a patient, the same patient that was presented initially, but the value of their troponin was changed. And when we look at the raw data and compare the original to the revised manuscript, you'll see that there were actually changes in the raw data points, not only for those risk factor matched control group, but also particularly in the COVID-19 hospitalized patients. So in summary for this particular publication, I would say that there is a suggestion that we are finding abnormalities on CMR in recovered COVID-19 patients. What we don't know is how many of those abnormalities were there prior to COVID-19, and also I suspect that the clinical significance of these abnormalities is possibly less than has been suggested by the mainstream media. But I think what this data does suggest is that we have an urgent need to improve our understanding of what's going on in the heart with COVID. And certainly there are lots of ongoing studies and registries going on across the world looking at this. But it's imperative that this research is of high quality. Ideally, it should be multi-center, analysis should be blinded, and data should be available for anyone who wants to look at it. And if we're comparing against healthy volunteers or risk factor matched volunteers, it's essential that we know what the normal ranges are for the mapping techniques on our scanner using that particular sequence, ideally with phantoms for QC. And finally, it's also important to know when we should be doing CMR in our symptomatic patients. And this is a very helpful paper that's been published recently from the Council of the American College of Cardiology, who have described 4 clinical scenarios where imaging may be needed. Patients with chest pain and an abnormal ECG in the context of COVID, those with hemodynamic instability, those with new left ventricular systolic dysfunction, and those with subacute or chronic ongoing symptoms. And in those patients, there are clearly some scenarios where CMR is of significant value. The question of whether we should be investigating those with subacute or chronic ongoing symptoms is less clear, and certainly at the moment there is no indication for asymptomatic screening of recovered COVID-19 patients using CMR. And that really reflects also what the STMR document that James put out recently suggests, and also what the European Society of Cardiology suggests, where they highlight the role of CMR for investigation of suspected myocarditis, but there is no role in asymptomatic patients. And finally, I'd like to reiterate that as imagers, we do have a responsibility to ensure that our routine CMR practice continues as best possible in the pandemic environment. We know that this is UK data, and we know that although deaths as expected from COVID were much higher in the months during the peak pandemic, we also saw that non-COVID deaths were higher. We also saw a reduction in the number of procedures for primary PCI for STEMIs after lockdown, suggesting patients were staying at home and not coming into hospital. And also we saw the time to revascularization, so the procedures within hospital got slower and probably less efficient. And it's important to emphasize to patients and their relatives that hospitals are probably safer than they might think. This is data from our study of asymptomatic healthcare workers studied serially over a 16-week period, which showed that at the time of lockdown there was 7% asymptomatic COVID-19 infection within healthcare workers. But very rapidly this fell in line with community figures, despite the fact that there were still lots of COVID-19 patients in the hospital, suggesting that PPE works. And that rates of transmission seem to reflect community figures really more than COVID hospitalised patient figures. So in conclusion, ladies and gentlemen, we know that the rates of hospitalisation and mortality from SARS-CoV-2 are higher in patients with cardiovascular disorders, and that troponin can be used as a prognostic marker acutely. The mechanisms of cardiovascular complication during acute COVID are multiple, and CMR definitely has value in symptomatic patients, particularly those where myocarditis is suspected. But I will reiterate that currently there is no role currently for asymptomatic screening using CMR in recovered COVID patients. And the imperative really at the moment is to deliver high quality research to understand some of the questions that remain. So thank you very much.